As I introduced myself before, I'm Mike Scaefer. I'm the chief of PM&R here at University Hospitals, and we're a division of orthopedic surgery. And I'll be doing two talks today. Actually, the next one on the agenda, Dr. Delzell's talk on ultrasound evaluation for Gluteus Maximus and neuromuscular electrical stimulation. Dr. Delzell had a death in the family. Her father passed away, so they're having services this weekend. She's unable to present. But we'll start with my talk on peripheral nerve stimulation with ultrasound guidance. I don't have any disclosures. I did use some slides from industry, especially from Bioness and SPR Therapeutics, the devices that I use most commonly. Also one from Nalu and pictures from one from StimWave. And those are the devices I'm most familiar with. We'll talk about the current options for peripheral nerve stimulation. It's different than what Dr. Lawrence talked about with spinal cord stimulation, similar to what you talked about with the Reactivate device, but different company again. And we'll talk about which patients may benefit and which nerves we most commonly target. As we all know, there's been an opioid crisis or epidemic in the country. It's overshadowed now by the current viral pandemic, but it's actually gotten worse during the pandemic. And so it makes non-opioid options for treating peripheral pain even more important. And this is usually neuropathic pain. So we know opiates don't work as well for this. There's so much of a crisis that way back in 2018, the Department of Health and Human Services came out with statements supporting the use of alternative measures such as peripheral nerve stimulation. And they mentioned that in particular, around the same time, they also increased the reimbursement rate for procedures dramatically. You can see by almost double. And you know that's fairly unprecedented in medical financing now for the payers to pay substantially more for procedures. And around the same time, most people have become proficient in ultrasound. Most people that perform pain management or physical medicine rehabilitation type procedures. And pictured on the bottom right here is an example of median nerve, but we see this in many different structures where the nerve tissue here, you see my pointer? Yeah, the nerve tissue there's fairly easy to see, not just in superficial structures like this, but even deep. And that as ultrasound technology continues to improve, it makes targets like this even more accessible right at the bedside. And you can see the picture bottom left is one of the new state-of-the-art ultrasound machines, and just happens to be the one that University Hospitals just purchased for my orthopedic clinic. So part of the question is how peripheral nerve stimulation works. And we think it's because it's blocking this vicious cycle of chronic pain by interrupting afferent signals that are afferent signals that are coming back to the central nervous system, and then decreasing central sensitization and maladaptive cortical plasticity. So we think that we can intervene, and the earlier we intervene in this chronic pain cycle, the better. So the two devices that I'm most familiar with, as I mentioned, is the Sprint PNS system and the Bioness Stim router system. The Sprint PNS is on the left. So this is a device, percutaneous device that's put in place for a period of up to 60 days. And the wires are left coming out through the skin and attached to a pulse generator that's externally placed. The Bioness Stim router on the right here is fully and permanently implanted system where all that stays in the patient is the lead, and then the pulse generators and battery are external. So this technology is relatively new, really developed in the early 2010s and researched in the decade before that, but commercially available and becoming more popular in the past 4 or 5 years. Again, the Sprint PNS system on the left and the Bioness system on the right. The Sprint system's introduced with just a needle introducer, a wire through a 20 gauge needle. And it's fairly simple to place, and you just put the wire in, pull the needle back out, and the wire stays in place, and then attach it to the stimulator for test, and then attach it more permanently to the pulse generator. The Bioness system, it's a fairly good description or fairly good depiction of the wire here. The target is down at the peripheral nerve. That's the active tip of the stimulator. And then the receiver is up at the other end of the wire. and only that wire and the very small receiver, it's almost identical in diameter to the wire itself, is put just in the subcutaneous tissue, and then that heals over. So the electrical stimulation, the pulse generator is outside the patient, and it's controlled by a remote. And there's a video upcoming that shows its implantation, or a kind of a cartoon video. There is a dual lead stimulator now from the Sprint PNS group, and a similar simulation system from Nalu. And I actually have my first patient now going through prior authorization to have a Nalu implant. It's somebody that I used the Sprint implant on 2 years ago, and this is pre-pandemic, and it worked while it was implanted, but she didn't have any long-lasting duration of effect from it. Although there are patients that do have long-lasting relief that we'll see in the little summary of research slides. The Nalu system is also fully implanted with an external pulse generator that attaches to the patient's skin. It is this little dime-sized stimulator. And the benefit of it is it's spinal cord stimulation type technology with many different settings. So it's a little bit more customizable to get an optimal stimulation pattern and waveform, and decrease motor activation and painful paresthesias. And then just for completeness, the other system that's being used commonly, maybe not as commonly, but is being used, including here at university hospitals in pain management, is the StimWave system. And again, it's spinal cord stimulator technology. The StimWave has a spinal cord stimulator, but then there's the StimQ device. That's the peripheral nerve stimulating version of that device. And again, it's stimulator and receiver wires with an external antenna and controller. Most of these devices now are going to smartphone or tablet platforms also for customized controlling, and that's very helpful for patients as well. But they don't have to have a smartphone or tablet. They can do it with their own dedicated controller also. So this is a little video showing implantation of the Stim router. It's really just a graphical depiction, and I took away the sound so I could introduce it. So this was really popularized before most people had ultrasound access or skills. So it can be done just with a peripheral nerve stimulator device through the skin. The target's identified usually with ultrasound. A little bit of anesthetic is given, not too deep, because you can cause temporary paralysis of the nerve in that distribution, and you can't test it with stimulation then. A small nick incision, less than 1 centimeter, is given. A wire introducer is placed to localize it near the probe. And the stimulating wire is done, and then test stimulation to get motor activation, to be sure you're close to that nerve. Then an introducer is placed. I'll try to move it forward for the sake of time here. Stimulation is given again, and then the lead loader assembly with that flexible lead is placed through this trocar. And the trocar is retracted just a little bit, or the introducer is retracted just a little bit, and then stimulation is given again. That deploys the leads, or doesn't quite deploy the leads. It deploys the active tip without deploying the tines to hold the lead in place. And when stimulation is successful again, then it's removed the rest of the way to deploy the tines to anchor the wire in place. And then the whole sheath is removed, usually with counter pressure against the skin so it doesn't displace. And then it's tunneled. So tunneling is just another small incision, and it's actually called reverse tunneling technique. It's common for introducing leads pulled back through the skin, and then the tip of the electrode, the receiving end, stays just underneath the skin. So these can be sutured for closure, or lately I've been doing them with even smaller incisions, and just a little dermabond is all that's needed. The patient doesn't even need to come back for suture removal. The new application, it can be programmed immediately. The original protocol was for programming 3 weeks afterwards, with the goal of letting fibrous ingrowth hold the lead in place. But since then, they found that it doesn't really need to happen. It can be programmed immediately. Patients still usually come back after 2 weeks for follow-up. So I'm going to skip that slide because it's not so pertinent. This is one of my own patients, amputee. And for some reason, whenever I project it, it stays sideways. On my laptop, it plays up and down, and I can't figure out how to fix it. But we have more volume. He gives a good description of it. So this is a many decades amputee. He had soft tissue sarcoma, lost his leg in transfemoral amputation in his 30s, and has had chronic nerve pain ever since. So fairly challenging patient who did well with the device. So he describes what it's like when he gets the stimulator, the external pulse generator, placed directly over the receiver. His words were, let me see if we can hear it. His words were, he feels like he's won the battle, but not the whole war. So
what it feels like.
There we go.
Where you have to put the needs.
Now,
More cutaneous or skin sensations.
yeah.
Yeah.
So that was
and it is placed on the sciatic nerve with implant site kind of mid buttock. I had to put it just below the rim of his prosthesis. We actually implanted him twice. The first time I put it high enough up so he could wear it above his prosthesis, but it was just too long of a reach. And with hip flexion, he pulled the receiving end of the electrode too deep to the skin to get good stimulation capture. So we just didn't have quite a long enough wire to put it outside of his prosthesis. His prosthetist said that he could cut a window in the prosthesis to put the stimulator there, but he's elected to not do that. He's happy with the relief that he gets at night when he's at rest, not wearing the prosthesis, and it carries over some throughout the day. So like I said, he said that he feels like we've won the battle. He can sleep much better. He's using a lot less medication. But he says, haven't quite won the war yet, but he's been reluctant, probably with the pandemic, to come and get his prosthesis window fits. I think he was thinking about waiting until he gets a new prosthesis and just having him build it into the new one. So same device, the Stim router, the more permanent implant, had the initial study come out in 2016. This is what got them approval. It was 104 patients with various peripheral nerve indications, but it also included post-stroke shoulder pain. We don't really know if post-stroke shoulder pain is because of neuropathic pain, but in some instances it is. This device in particular with post-stroke shoulder pain, we think acts somewhat like functional electrical stimulation because it does activate the teres minor through the axillary nerve. And when the teres minor activates, the shoulder actually stops subluxing in some cases. Actually, I've seen it in my own cases. So in this study, 104 patients, about half of them had post-stroke shoulder pain, and the rest had a variety of different pains, including sciatic pain. And they looked at functional outcome measures besides just pain relief, which was also significantly significant. They had walking ability to do normal work, sleep, and enjoyment of life. And they all had very highly significant improvement rates. So the company has since gone on to develop a registry, a multi-center registry for ongoing studies, and they have multiple that are going on. I've actually registered UH as a study center, but I have yet to enroll a patient. I'm not getting a whole lot of referrals for this currently, but it's just about ready to enroll patients. They will have up to 30 centers when they're at their peak of number of enrollees. And it can be any pain of peripheral nerve origin. And it's going to go on for 60 months with multiple study indicators. They did do a subsequent survey on the 104 patients from the original study. This was published 2 years later, but they had data up to 5 years afterwards that were included. And overall, the average pain reduction of about 60%, and a 65% responder rate, which I believe was 3 points on the numeric rating score. And of the 104 patients, 37 had reduction in opiate use. 37, I think, were on opiates, and it resulted in a 67% reduction in opioid use. My own patient, the first one I ever implanted with post-stroke shoulder pain, was able to get off of opiates. It was a very challenging post-stroke shoulder 2 years after stroke. She was in West Virginia, where the opioid crisis is at its worst of anywhere in the country. And she was using OxyContin 20 milligrams twice a day and 10 milligram oxycodone for breakthrough, multiple per day. I think it was 4 per day. And she was able to get off of the opiates completely. And that was after about 6 weeks. It was a very good response. She was the first one, and I thought it was too good to be true. Actually, I thought the company maybe was setting me up with just some test patient who was paid to react this way. But she was very legitimate. We put the stimulator on, got activation of the teres minor, so much so it stopped her subluxation. And she was only lightly sedated for the procedure. That's how I prefer it, so they can report their sense of paresthesias. And we turned the device on, and she said, "Oh, that feels so good," right away. First words out of her mouth. And we turn it off in between tests and implantation. And she said, "Turn it back on, turn it back on." So she was like, right away, she wanted. Of course, there's a lot of wishful thinking, and patients really want the device to work. But in this case, it really seemed to. And that was a very good start to this journey I've been on with peripheral nerve stimulation. So, other discussion of research. Now, this is for the other system, the Sprint PNS system. This is a lot of this research was done here in Cleveland at Metro Health and Case Western Reserve by my former partners and colleagues, John Shea and Rich Wilson. And so they were done most on post-stroke shoulder pain, but there have been many other studies underway, and some of them have been published since this slide, including studies on chronic low back pain, post-amputee pain, and knee arthroplasty. And there are studies that are planned for multiple other areas. And in general, this is lumping the data. In general, they have 87% clinical reduction in pain, or 30% reduction in numeric rating score. And up to 78% with data out 12 months post-treatment. And 72% had a 50% reduction. So those are more high responders. And this is just after a 60-day or average of clinically, we use a 60-day implant. Some of these were only implanted for 30 days at a time and still had some sustained relief. So this is just a graph comparing, and very similar data actually between the original study with Dr. Che in 2005 and subsequently repeated with a single lead by Rich Wilson in 2014. This is longer term treatment out to a year, showing a significant reduction in conventional therapy, in Sprint PNS therapy versus conventional therapies. And then another interesting slide with a study on early peripheral nerve stimulation versus late. And this is all the way out past a year also. And they showed that the PNS group in early stimulation had a significant and sustained relief. The PNS group in the late group had a significant relief, not quite as much, and then gravitation back towards the control group. So some rationale to get this treatment on board early on. And this is a separate study looking at PT as a comparator with a very significant improvement in favor of the Sprint PNS group. Again, that's Rich Wilson. So I have videos and more data on each of the device, including ultrasound, but for the sake of time, I decided not to include those today. So like I said, it's pretty promising, especially for select cases. I think in my own experience, probably about 50% of the patients are getting good relief. But these are challenging patients. Most of them that I've seen have been very chronic and fairly high pain levels, and something that we don't have very many other good options for. So something that's very simple and can be implanted just with ultrasound guidance with a little stab incision at most, in many cases, just a little needle insertion. I think it's very promising. So I'll take questions.
How do you, when you sort of try to confirm the test where you'd like to place it, how do you go about like identifying to utilize this?
That's good question. There's usually pain is in the distribution of that nerve. And there are some windows, ultrasound sonographic windows where we know the nerve is easier to find. So for post-stroke shoulder, as I mentioned, the axillary nerve, but a lot of people are using the axillary and the suprascapular nerve simultaneously. There's a general tendency for people to do nerve blocks diagnostically, but the research has shown that there's poor correlation with response to the block and the actual response to the stimulator implant. So we're trying to de-emphasize that also to have it so insurers don't require a response to a diagnostic block before implantation. Because the block itself is only slightly safer than the implant itself, or more difficult than the implant itself. All right. Other questions? I'll move right along to Dr. Delzell's talk here. It'll be a little shorter. We'll get us on time, I think. So this was actually supposed to piggyback right after Dr. Konidis's talk on glute max rehab. And just so happens Dr. Delzell is former partner and colleague at Cleveland Clinic. She was the director of musculoskeletal ultrasound at Cleveland Clinic and has since completed an integrative medicine fellowship and opened her own practice, advanced musculoskeletal medicine consultants in Novelty. That's the far east side of Cleveland. She's still doing musculoskeletal ultrasound and interventions. And she's very good with ultrasound. So she's still a good resource for us to use when we have challenging patients. She had no disclosures. Objective is to review the anatomy of the gluteus musculature, especially the gluteus maximus, and review the use of a neuromuscular stimulator for improving the gluteus maximus contractility. And she wanted to talk some about the anatomy and the kinetic chain, but I think Dr. Konidis described this fairly well already this afternoon, how the gluteus maximus actually works as part of the sling system to provide support for the core, or actually as part of the core. It is active at different points in the gait cycle, and this kind of describes how after the mid-stance phase, there's actually more cross activation of this kind of posterior sling. And again, I'll stop, or I'll skip the summary there. Again, as Dr. Konidis mentioned, a lot of attention has been paid in therapy and kinetic chain theory to the gluteus medius, but we think the gluteus maximus is probably just important, if not more so. And it makes sense being such a large, powerful hip extensor and stabilizer. The application for gluteus maximus activation, I think, in Dr. Delzell's and my own practice, came from seeing so many patients with severe gluteal atrophy. And she and I both kind of made a practice, or filled the majority of our practice at Cleveland Clinic with refractory hip pain patients, many of them even after total hip arthroplasty with continued pain. So that kind of begged the question, why are these patients so deactivated, and how can we assess them besides just looking at the anatomy and looking at the x-ray? And the classic story as well, the hardware looks perfect on x-ray, so you just need to do more rehab. But some of these patients just were not able to rehab. So with ultrasound, we can actually look at the muscles, and we can look at it dynamically. And so this is a breakthrough compared to the conventional MR imaging. And we think the patients who are not dynamically activating the gluteal musculature despite trials of therapy, could just be not doing the proper therapy, but they also could have some underlying defect in contractility or some other neuromuscular factors that go into deactivated gluteals. So one example of what we run into here on ultrasound is a classic trigger point, or maybe you might call it a chronic strain of the muscle with reactive spasming. So on ultrasound, this looks like a hypoechoic region. You can see subtle fiber disruption. So the fibers should look linear like they do all across the superficial part of the muscle. And I guess I can orient you here that I like to count layers when I'm teaching ultrasound. So you look at the skin is bright, somewhat hyperechoic. Subcutaneous fat is hypoechoic, very variable. In the gluteal region, it tends to be very dense and sometimes makes imaging the underlying structure is more difficult. So it's good to have high quality ultrasound equipment for this type of thing. So skin, subcutaneous fat, gluteus maximus is very large muscle here over the top, and then small external rotators, piriformis and gemelli are deep. Gluteus medius, if you're up higher on the, or more anterior on the iliac crest, you can see gluteus medius underneath the maximus also. But this area could be an area of strain that looks like this, or could be a trigger point. Sometimes they're tender, sometimes they're not. It's important to correlate clinically what you're seeing, because you see abnormalities in many tissues, as we know just from reading imaging, X-ray or MR imaging. Sometimes they're asymptomatic, but this is something that we see when we are looking at the posterior hip. Sometimes trigger points, they'll look like normal muscle, even with ultrasound. So usually with MRI, they look like normal muscle. Even a fairly significant strain can still look normal on MRI, but we see it with ultrasound. And sometimes the trigger points look like normal muscle also, but they'll be ropey and firm and they won't move dynamically. And with palpation, you can feel a trigger point. Most of you probably have felt a trigger point, and we use that to target injections. But all you'll see with ultrasound is that that section of the muscle moves when you tweak it more suddenly, or it'll roll like just what you feel under your skin, but it'll still look like normal muscle. I put quite a bit of work into trying to figure that out with patients that I know responded to trigger points and came back repeatedly. And most of them, I couldn't tell a difference looking at the muscle architecture. We also see scar, and scar can come from intervention. The surgery itself sometimes will do this, sometimes just from localized trauma, previous hematoma, injury, strain, vaccination. A lot of things will cause trauma, but this is an example where there's chronic scar. So normal muscle tissue is deep, it's dark, hypoechoic. You can see fibrils through it. So more superficially here, it's a large area that's hyperechoic, and kind of some people call it ground glass appearance, or more hazy appearance. And we'll see areas of scar that don't move naturally also. So we have a few videos here. This is normal contractility, and this is a little difficult to follow. So I'll try to talk you through it and I'll toggle back and forth, but you can see the entire muscle here shortens with activation. So this is mid-belly of gluteus maximus. The patient's prone and just asked to extend at the hip, and that activates the gluteus maximus. Let's do this again. So you can see this is a really meaty, big gluteus maximus all the way through, from subcutaneous fat layer all the way through to the deep rotators. And you can see the whole muscle activates and contracts into kind of a ball, right? So look at this kind of ball shape or football shape structure, fusiform for use the proper medical terminology. But you're looking for something that looks like a football when it's after it's contracted. So this one is an example of poor contractility. So a similar structure though, and fairly good bulk for a gluteus maximus. I'm not sure what the scale is on these ultrasound images, but you can see it's barely moving with the same activation pattern. And you could probably detect something like this clinically too. You can see that the buttock's just not activating. So I like to have the patient prone, flex the knee to put the hamstring at a position of disadvantage, and then have the patient extend at the hip, or just lift their knee up off of the table. You can do it sideline if they don't have enough hip extension range of motion to do that. And this is the opposite side for comparison. Also not good activation, but a little bit better. So you can see the muscle kind of shifts or moves. And really, like I said, you should be able to detect something like this clinically. But in the subsequent examples, if I can get the slide to advance here, in the subsequent examples, it may not be so obvious. So this is also poor contractility, but there's enough contraction, enough movement, shortening, that the muscle seems like it's activating, but qualitatively, compared to that first study or the first image that I showed where the muscle contracted and actually looked like a football afterwards, the muscle still looks pretty flat here. And you can also look carefully that the deeper fibers seem to be activating better than the superficial fibers. And that's fairly common to see. According to Dr. Delzell, I haven't really identified that pattern. I don't do this very much, but this is preliminary work for a study on electrical stimulation, or neuromuscular electrical stimulation that she was doing just around the time that we both left the Cleveland Clinic. So So this is partial dysfunction. On the left is study mid-muscle belly. Again, skin, subcutaneous fat, gluteus maximus from about here to here. Not as much muscle bulk to start with, and doesn't activate very well. But farther distally and laterally along the course of gluteus maximus, that part of the gluteus maximus is activating fairly well. So it's an example of how the more superior part may be a separate branch of the nerve going to that area, or it could be scar or previous muscle damage that's inhibiting, or just a learned movement pattern. It may not activate the muscle well. And this is another example of partial dysfunction. So again, the inferior parts seem to contract a little bit better. So when she's considering a patient for neuromuscular electrical stimulation, she likes to see poor contractility. They tend to respond better if it's fairly diffuse in the muscle versus one focal small area. And it's used for treating the underlying atrophy. But we need to keep in mind to look for other causes, especially lumbar nerve issues. So L5 or S1 nerve compromise can do this to patients. Less commonly peripheral nerve entrapment, but still could be a source. And then usually neuromuscular electrical stimulators are used for larger muscles. So they're very good for gluteus maximus. She used in her study the Symedica device. I'm not sure if that's what's depicted here, but there are multiple commercially available devices. They're covered by the patient's insurance. Their protocol in her practice is to use just 20 minutes every other day for 1 to 3 months. So fairly infrequent, but for a longer duration of time. So for up to 3 months prior to reevaluation. And she has had anecdotal evidence only. Now, unfortunately, she didn't have data to present here, but anecdotally, she says she's getting very good response. I asked her on email because I figured it could come up, and she said about 80% are responding or showing improvement, but we still need data to show it. But this is post-treatment. You can tell there's some atrophy in the gluteus maximus. It's a little bit brighter, so there may be more fatty infiltration in the muscle. Still fairly good bulk here, but you can see it does activate. And you can almost imagine a football shape here. So, and that is all she had.
I hope you're enjoying the virtual meeting. If you have any questions, please feel free to email me at the email on the slide, and enjoy the rest of the session.
I thought it was a cool little addition she put on for to actually get her voice out. So I'll take questions for her and I'd be happy to pass them along also.
Focuses glute maximus to go with mass medius and then mass
Mm-hmm.
especially with hip arthroplasty patients or rehab resurfacing patients.
Mm-hmm.
That area of the hip is becoming challenging. So my question is, have they looked into doing similar treatments?
Yeah, the question has anyone looked at doing similar treatments or evaluation for the other gluteal muscles? I know that clinically Dr. Delzell does, so she has talked about it. I'm not sure why they chose gluteus maximus as the source for their study, but when we first started doing this, it was gluteus medius that she was looking at most often.
Is the stimulation applied in a passive manner, or is it completing an exercise?
Let me go back up and see if it says. The question from Ben Goletka here was, is the stimulation done in an active manner associated with exercise, or is it just passive stimulation? I believe it's passive stimulation, but I'm not completely sure. So.
Try to get a prescription in order to get them to do it for home, but they're utilizing stimulation protocol with an isometric contraction along with it to try to get that done at home. That's one less thing you got to worry about there. But it's pretty similar with a lot of these protocols too.
Mm-hmm. Yeah, the comment was that they tend to use in therapy, especially with the ACL rehab, that when they use electrical stimulation, they have the patient do isometric contraction with electrical stimulation at home. And it seems like that would make sense also. I may be misunderstood. I didn't read the study or participate in it when she was designing it. So it may be active also. Okay, other questions? All right, thank you for your attention.